All right, Neil,
Okay,
shall we make a start then, yeah?
sure. So a very warm welcome to everyone to our Glasgow People's Health Inquiry, an event run by People's Health Movement Scotland. My name is Neil Quinn. I'm a professor in the School of Social Work and Social Policy at the University of Strathclyde, and also a member of People's Health Movement Scotland. We're absolutely delighted. There's been such a great turnout today for such an important topic. I can move these on, Tony, is that right? Could you move on? Sorry, I'm struggling to move slides. So the overall purpose of today's seminar is to hear your views on Glasgow's current health and health inequalities and how we might address these in light of the COVID pandemic. Also in terms of austerity and the climate emergency. This is an online public inquiry to draw together evidence and reflection about health and health inequalities in Glasgow since the start of the pandemic, and to consider what the future might hold, especially in terms of the climate crisis and local government underfunding and current political decision-making. We'll hear evidence from a diverse range of sources. So this is our programme today. We'll have a plenary by Kat Smith on health inequalities. There'll be evidence submissions from 15 contributors, each with 4 minutes. And we'll then hear responses by representatives of a number of organisations at 4:15, and then we'll finish with closing remarks. This event is sponsored by Stop Climate Chaos as part of Climate Fringe Week. We'll be recording the event so that we can share it later. And we'd like to encourage you to introduce yourself via the chat and use this chat to discuss any topics that arise, any reflections that you might have. Again, we'll record this and this will help us in producing a report later on. We're aiming to produce a follow-on report and have further meetings to implement the report and also to support our dissemination and activism going forward. We'd encourage you to tweet and the Twitter handle is @PMH Scotland. I'd also encourage you to check our website, which is peopleshealthmovementscotland.wordpress.com. I just wanted to say a bit about the work of People's Health Movement Scotland, which has been a social movement in the field of health rights and health inequalities now for a number of years. And there's a number of activities that we've been engaged in over the last few years. One has been the development of a health watch, which is an emerging space for people, organizations and movements to collectively share their ideas, actions and thoughts. We've been involved in producing human rights reports, including shadow submissions. There's been a number of events, including people's health assemblies, hustings, particularly around the time of UK and Scottish and local elections. And there's also been a number of public awareness raising events, including Declaration Health and Human Rights Festival that we've been involved in holding events at, the Edinburgh World Justice Festival and other events. So our mission really is to raise awareness, but to also influence policy around health inequalities and health rights. So as I mentioned earlier, that's the purpose of today's seminar, is to hear views on Glasgow's current health and health inequalities and how we might address these through this online public inquiry. Okay, so I would like to move on to our first speaker, Kat Smith, a colleague of mine from the University of Strathclyde. She's a professor of public health policy there, is a leading expert on health inequalities and has recently written a really interesting and engaging book on the impact of COVID on health inequalities. So welcome, Kat. Delighted you can join us today.
Thanks very much for the invitation, and it's lovely to see everyone here. It's a great lineup. I'm going to make sure I don't take more than my time because there's so many other people to hear from. Tony, I just want to check, like with me, how do I move from the next slide, one slide to the next?
So it should just work either with your keyboard, the down arrow or the right arrow. Should kind of work. So you've kind of got control of my screen, essentially. Perfect. So don't do anything, too crazy with it.
Okay, yeah, thanks very much. So I'm going to give a bit of an overview of this book, which is a co-authored book, The Unequal Pandemic, COVID-19 and Health Inequalities, that I wrote with my colleagues Claire Bamborough and Julia Lynch. And the idea of this book is basically that we were trying to bring together the emerging research on the intersection of inequalities and the COVID-19 pandemic in an accessible format. So as an outline, I'll say a little bit about some of the data on inequalities in COVID-19. I'm going to apologise in advance that this data analysis is led by Claire, so I'm going to skate over it a little bit, and B, quite a lot of it comes from England. And while there are a lot of similarities with Scottish data, there are other people on the call I think I'll be talking about the Scottish data more specifically. Then I'll touch on ghosts of past pandemics. We look a bit at the book at some of the similarities between the COVID-19 pandemic and previous pandemics. I'll introduce the concept of this being a syndemic pandemic. I'll then talk about some of the collateral damage that we've seen as a result of COVID-19 and the policies that have been implemented to try and mitigate COVID-19. I'm going to emphasize, as we do in the book, the importance of policy choices to address inequalities, and I'm going to end with some reasons to be hopeful to try and see this as a moment for policy change. So in terms of the inequalities that we've seen in COVID-19, at the big picture level, they're very similar across the UK, and they are sadly what we would do. Those of people who've been looking at health inequalities for the past few decades would have anticipated. So we've seen that in the more deprived areas, people have been more exposed. They've been more likely to get COVID-19, and then they've been more likely to suffer serious consequences or mortality. So that's the same kind of pattern that we see across various different health outcomes. If you can map that regionally, and obviously, sadly, this is a map of England. So here, what the emphasis point for this visual really is to show that we have this inequality not just between deprived and affluent areas, but there's also a regional inequality between in the north and the south of England. I have less sense of the Scottish data, but I'd be surprised if we don't see something similar between the west of Scotland and the rest of Scotland. In terms of occupation, it's again broadly what we would have expected. Obviously, some of this has flowed very directly from the fact that some occupations and people have been able to work from home, whereas others were encouraged or by necessity had to continue to go to work. And some of those workplaces were not safe environments and didn't have PPE and other protective measures put in place at the start. So we were asking or requiring people to go into situations where they weren't safe, and many people did get exposed and catch COVID-19. One of the things that I think has been a bit different about the COVID-19 pandemic and previous research on health inequalities in the UK is that there has been much more emphasis on ethnic differences. So ethnic differences in health have long been studied in detail in some contexts, including the US. But there wasn't a huge amount of research on this topic in the UK. And in fact, as COVID-19 made clear that there were these really worrying and extensive differences between some ethnic groups. You can see here on the right, the data from England. You can see we had much higher mortality rates in Asian and Asian British and in other ethnic minority groups than in white and white British groups. So we've seen these kind of worrying trends, and in Scotland, I think it opened up a really important conversation around the fact that we weren't even capturing some of the key data around ethnicity that we needed to be in order to understand this problem. So that has been something that's been really difficult, but I think has opened up really useful conversations, intersecting conversations between structural and institutional racism and work on health inequalities and the social determinants of health. If we look at past pandemics, so data from Norway, Sweden and the US shows inequalities in the 1918 Spanish flu epidemic, and there's higher incidence then in mortality amongst the working classes, unemployed and lower occupational groups, which is obviously then followed a similar pattern to now with the COVID-19 epidemic. And we see this urban-rural divide in England and Wales, which again, we've seen in the current pandemic. So you can see this map here of regional inequalities and mortality rates in the 1918 Spanish flu epidemic and pandemic, and you can see that that map has some striking similarities to the map of COVID-19 mortality rates. So my colleague Claire has argued that what we're experiencing, we could perhaps best understand as a syndemic pandemic. And this concept comes from Merrill Singer's work on the HIV epidemic in the US. So he defines the syndemic as a set of closely intertwined and mutually enhancing health problems that significantly affect the overall health status of a population within the context of a perpetuating configuration of noxious social conditions. And in effect, it's what this rainbow model of the social determinants of health that's widely used in health inequalities. I mean, it really is just describing that kind of context, but now its intersection with the pandemic, which is what Claire's depicting there in that diagram on the right-hand side. The syndemic pathways to inequality are first, groups that were already experiencing a higher burden of non-communicable diseases, so things like heart disease and cancer from social determinants, were then more vulnerable to COVID-19. People were also increasingly susceptible because of impacts on their immune systems being weakened by long-term exposures to adverse living and environmental conditions. They were then exposed more, and this issue around people who were required or needed to continue to work for income and so on. So they had increased exposure, and then there was increased transmission because of things like housing conditions. And if we look at the data on ethnic inequalities, there's also issues around multi-generation or households and so on. If then we move to the collateral damage, so this is thinking about the inequalities that have arisen not just as a result of COVID-19 itself, but of some of the policy responses that were put in place. So many of those who've been most susceptible to COVID-19 directly have also been the most susceptible to these kind of indirect collateral impacts of these policy choices, because, for example, they were unable to work from home. Some have opted not to work or have lost their job, so obviously then that impacts income and stress on the family. Others have continued to work, but risk not only to themselves, but also to their families. And here there's a story that was written up by a doctor working in the northeast of England, who many of you might have seen this story. It was covered on the BBC News website. It's about Karen, who's a hospital cleaner, and she had a partner who worked as a hospital porter. I think he had underlying health conditions. So they decided between the two of them that he would be the one that would not work, but they couldn't afford for them both not to work. She would continue. They were caring for his father, who was elderly and had underlying health issues. So she continued to work in the hospital as a cleaner. She then contracted COVID-19, brought it home. Both her and her partner were ill with it. Her father, who they cared for, even though they tried really hard not to pass it on, unfortunately got it, and he died. She then is left with this complicated set of factors. So it's impacted their income, it's impacted them as a family. They've lost a member, they're going through bereavement. She's also got long COVID. So you see this kind of multiple ways in which someone in that situation has had very limited choices. They haven't been able to make the choices that some of the rest of us have been privileged enough to be able to make to avoid the worst of this pandemic. If we think about it internationally, we've also seen like kind of large scale examples of the way policy decisions and people's socioeconomic situations have interacted. So in India, there was kind of sudden decisions for migrant workers who'd moved from rural areas to the city for their jobs to stop, and then en masse kind of trains, and not enough trains and buses were put on to take people back to the rural areas. So what you were effectively doing with that policy is squeezing lots of people who may have been exposed to COVID-19, some of whom certainly were, into small confined areas where they were almost inevitably going to transmit it, and then sending them back to rural areas where, again, they were going to transmit it. And we saw how bad things got in India following some of those decisions. We've also seen things like various aspects of inequalities which have been framed as shadow pandemics. A key one is violence against women. There's also been much concerns around abuse against children. Obviously, if you've got people living under the threat of gender-based violence or abuse in the home, then a policy that's put in place that requires people to stay at home is inevitably going to make things much worse for you. So you've got those things going on, and at the same time, people on the front line who would often be offering support, including NGOs and social workers and so on, not being able to do their jobs and offer those services in the same way. But in all this, policymakers have and make choices, and they can make choices to better address inequalities. So if we think about some of the things they could do on the policy side, they can expand social safety net programs, and we have seen some of that being put into place, some in the UK, not as much as we would have liked in terms of the furlough scheme and so on. It can increase access to affordable, high quality healthcare, including mental health services and childcare. You can strengthen policies that act on the social determinants of health, including stronger enforcement of environmental regulations and things to address poor quality housing. And you can choose to implement policies that reduce inequalities in income and wealth. Some of those things you need to do in advance, and we went into this pandemic in the UK and Scotland not in a great condition, because we already had very high inequalities and we'd already been experiencing the austerity programme when it comes to welfare and benefits. But some of them were about decisions that were made during the pandemic. On the politics side, we can think about how to balance the power of large corporations with union protection to improve working conditions. We can think about recruitment, so we've got more diversity in who's representing us, working hard to combat voter suppression through civic education, mandatory voting, so on. That these recommendations came very much from Julia in the US context, and then consider ways of facilitating constructive public conversations about tackling inequalities. And so on the final slide, I'm just going to end on some reasons to be hopeful. So one is that the pandemic may stimulate progressive economic reforms. It certainly stimulated a conversation about the extent of economic inequalities. And in the book, one of the things we note is this rising economic inequality that you get as a result of some of the policy choices that have been made in the UK. We also have the re-emergence of scientific expertise in public and policy debate. So now we're definitely in an era where most people have a sense of what public health is, and they're hearing from scientists on a really regular basis. There may be some pushback to that, but it's also potentially an opportunity to build on that in terms of helping to get more evidence-informed policy responses. There's lots of literature showing that past social upheavals have served as opportunities to rejuvenate democratic engagement and reforms, and so it's possible that this may be a similar kind of opportunity. We've seen policymakers take macro level policy action in ways that were unimaginable prior to the pandemic, at least to many in this generation. And having done that to tackle this issue of COVID-19, and I know Gerry's on the call and he's written a paper with some colleagues kind of emphasising how many more deaths are caused by health inequalities more broadly. And if policymakers can take this kind of macro level action to tackle COVID-19, then surely we can also take it to tackle health inequalities over the longer term. There have also been some positive environmental impacts. So we see opportunities there to progress climate change agendas. But, you know, I mean, it was obviously unimaginable that planes would stop flying at the extent that they have. And many of us have stopped traveling to the extent that we previously did. And then there's the direct and indirect impacts of COVID-19 kind of highlighting the futility of social discrimination and division. And so there's a bit of a literature around how migrants have been treated and so on, emphasizing when you've got a communicable disease like COVID-19, you can't stop that disease from spreading. So if you're not treating certain sections of your population well, and you're not giving them the healthcare and services that they need, then they are going to experience that disease, but it's going to spread from them elsewhere too. So people are using that argument in the kind of migration sphere to make a strong, much needed case for trying not to treat those communities so differently. And that's the end of my overview. Thanks very much to everyone. Hopefully I've kept the time. Looking forward to hearing everyone else's contributions.
Thank you very much, Kat. That was a great overview, and yeah, lots to think about. You know, covered a lot of ground and kept exactly to time, so thank you very much. We have, I think, a few minutes for a couple of questions. Actually, just to raise your hand if you've got a question or comment on Kat's presentation. Nobody coming in?
I think Mark Langdon's got his hand raised.
Right, Mark, sorry. It's quite hard.
Scott's got his hand up now, so I'll let Scott come in.
Right, Scott, do you want to come in? Can't hear you, Scott. Are you on mute?
Thank you. Thanks. Yeah, and thanks for that, Mark. Yeah, sorry. Yes, my name's Scott Donohoe, part of the chat and chair of Scottish Hazards, which is a health and safety charity, and I'm also a branch officer with Unison, Glasgow City branch, local government, which is about 13,500 members. Obviously, just to say thanks for that presentation. It's just a point about policymakers or policy decisions. I absolutely agree with the fact that there could be reasons to be hopeful, as you absolutely rightly point out. Some of the stuff that government done during the pandemic, when prior to that we'd done unthinkable. So I think the issue we've got with governments across the four nations is that issue about policy decisions and actually changing policies. The massive gap in inequality is, as you just pointed out, is horrendous, particularly in Glasgow, where I work and live. And I think with my trade union hat on, we have got a lot of work to do in terms of trying to tackle that imbalance. But I'll touch on that later. Thanks.
Thanks very much, Scott. Mark, do you want to squeeze in a comment, and then I'll ask Kat to respond to both?
Yes, no, I think Kat's overview is brilliant, but I'm interested in what is missed out, and what is missed out is the huge widening of inequalities because of wealth at the top also growing. And particularly find these the clawback of the £20 a week uplift of universal credit as something which seems particularly cruel and inhumane. And I'm just interested in how these, for me, these kind of policies, you know, they fly in the face of any kind of research-based, even any kind of sense of a central moral ground. And the UN has been quite outspoken, which, you know, they're not usually well known for. But I'm just interested in how the public health sphere responds to what, in my view, just seems like, you know, brutality and inhumanity. And how do you come up with research that tackles that positively? So I'm interested in how, you know, in the real world, when we see these policies enacted, what are we meant to do?
Thanks very much, Mark. Kat, do you want to respond briefly to those 2 points? So quite a big question from Mark there, but hopefully you can have a response to it.
Yeah, no, it is a big question, and it's exactly the kind of question that People's Health Movement is trying to tackle, isn't it? And it's why it's important we've got organisations like People's Health Movement. So on this issue of widening inequalities, I completely agree. We do go into that a little bit in the book, and it is shocking that the wealth increases that we've seen in the top like 1% really of wealth during the COVID-19 pandemic. But that's on the back of kind of a much longer term trend, and we do, I think, in my field, social policy and social work, tend to focus on poverty and the bottom end of the social economic spectrum, people who are experiencing the brunt of things, and I think we do that for good reason. But I agree that it misses out important of an analysis of what's going on at the top end. There's some really good work by people like Kevin Farnsworth looking at where state subsidies go and how much subsidization goes on of really wealthy communities via things like private schools and so on, but not only, also corporations, tax breaks and so on. And then there's work that I've been involved in looking at how large corporations influence policy to their advantage. I do think we need more of that work, and we need to bring it into conversation with the work that's looking at inequalities and looking at poverty and so on. And I think one of the things that we should be doing in response is trying to bring that more into the public conversation, because I think people lack awareness of how much subsidization the state is offering to very wealthy communities. On Scott's point, I guess I'm always trying to be hopeful, because I feel that it's partly how you get by, but it's also, for me, a way in which you achieve change is by trying to visualize and work towards the more positive outcome and to achieve that. If you're always only emphasizing the problem, I think it doesn't help you get others on side and kind of really feel motivated that actually this is something we could do something about. So that's why I'm always trying to think, what are the positives here? I think basically that's a political act. You've got to find ways of visualizing where we could be and where we want to get to.
Thanks very much, Kat. And thanks very much for your talk again. I'm going to pass on now to my colleague, Tony Robertson, who's going to introduce the evidence submissions. Thanks, Tony.
Thanks, Neil, and thanks, Kat, as well. So just get this up. So this is the session where we're going to move on to the kind of smaller little chunks of evidence that we've asked people to submit via the call today. So each speaker has 4 minutes, and we're going to try our very best to keep everybody to their 4 minutes, because obviously there's quite a few speakers, as we mentioned. There's kind of 15 contributors over the next little while, so it's quite tight for time. So I will time it in the background, and I will shout out if you're getting close or you're sort of running to time, and then I'll probably just mute you if I have to, if you won't shut up. So I'll be a strict chair as best as I can. So first up is Gerry McCartney from Public Health Scotland, from the Scottish Public Health Observatory. Although I did see in the chat he's also got a new role. He's also becoming an academic even more and more every day that I hear from Gerry. So Gerry, over to you for this presentation. So, and I'll hand you the remote control as well. So.
Okay, thanks, Tony. And there's a lot of money riding on me doing this in 4 minutes, so I'll crack on. And thanks to Kat. So Kat's outlined a lot of the things that I'm going to talk about, but I suppose what I will do is decorate that with some Scottish data, albeit very, very quickly. So I'm going to talk about very, very briefly some of the pre-pandemic health inequality challenges, and David Walsh will revisit that later on. I'll talk a wee bit about how socio-economic inequalities have been seen in Scotland through the COVID pandemic, and then just to rehearse some of the mechanisms that have led to that inequality. So in terms of some of the pre-existing challenges, this graph shows the rate of improvement in life expectancy in Scotland in the decades running up to the pandemic and running up to this decade, in fact. And you can see that in most years, Scottish life expectancy for males increased by about 10 to 20 weeks of life expectancy a year. But that just dropped off a cliff over the last decade, such that we've seen almost no improvement in Scottish life expectancy for men and for women over the last decade. So even prior to the pandemic, we had a crisis here. And you can see that that was the projected life expectancy improvement in Scotland between 2012 and 2018, and that's the actual rate of improvement. So you can see that there was a big problem in Scotland around its health prior to the pandemic. That problem was most keenly felt in our most deprived areas. So you can see that in the most 30 or 40% of deprived areas in Scotland, life expectancy was actually worsening. So mortality rates were worsening over the last decade. So it's not just a question of stalling for the most deprived, it's actually a question of things getting worse. And I don't think I need to convince many people that the economy and the changes to economic policy over the last decade have been the biggest driver of that, and in particular austerity. And as I mentioned, David will cover that a little bit later on. So how have socioeconomic inequalities impacted through the COVID pandemic? Well, what you see here is COVID cases through the different waves, and you can see that in the most deprived areas there was markedly higher case rates in our most deprived communities in Scotland, and that's led to a gradient across deprivation quintiles, or fifths of the population, that has seen about half to a third more of cases in our most deprived areas. I'm focusing here just by dint of time on socioeconomic inequalities, but Kat's quite rightly drawn our attention to other forms of inequality that we've seen through the pandemic, including ethnicity and by gender. Now, those inequalities in COVID cases have translated to even more stark inequalities in COVID deaths in Scotland. So you can see here again, the peaks are much, much greater in our more deprived areas, leading to an even steeper gradient across deprivation in Scotland for COVID-specific deaths. And that's because of the greater impact of a case in our more deprived areas, because of greater pre-existing health conditions, less resilience, less income, less material conditions to cope with COVID when it does come calling at the door. So what are the mechanisms that are behind all of this? So, sorry, one more slide on this. Just to say that area-based deprivation measures underestimate inequality. So if you look at individual measures of socioeconomic position, the rates are 11 times higher in our most deprived groups. So very briefly in 30 seconds, the mechanisms underlying this, I've illustrated that even before the pandemic, austerity, precarious employment, the changes in the economy were already causing stalled life expectancy trends, but then COVID has impacted directly through virus exposure, transmission, susceptibility and death, but also indirectly through the economy and the impacts on education through our children and indeed people in further and higher education, all of which have impacted more on our deprived communities, all of which has led to a worsening in health inequalities. And with 1 second to go, that's me. Thank you.
Thanks very much, Gerry. So I think what we will do in this is we're not going to necessarily take questions just because of the timing of the sessions, I should have said before. So we're going to kind of rattle through each in turn. So next up we have Dawn Fyfe from Wise Women, who's going to present as well using the slides. And so I'll give you access to the slides in a second, Dawn, as well. So.
Thanks, Tony. Thanks very much for letting us to respond to the inquiry. We kind of feel that some of the difficulties that Kat and Gerry's shown that pre-existed COVID, and we're awful keen now to see that our responses aren't being seen as separate to COVID as it is in general times, because we tend to respond to crisis in the same way. So thanks very much for allowing us to contribute. Wise Women's been around since 1994. Oh, I'm not getting to move. Sorry. Oh no, I'm taking up time.
That's all right. I think you should have a light on. Sorry. Okay,
thanks very much. We're around since 1994. We provide personal safety courses, competence building courses, and also have a strategic input into Glasgow City Council. And we also do consultations with women. All our services are about increasing women's participation in society, and we do this by decreasing barriers through our strategic work and also increasing women's confidence and safety in our groups and courses. I thought the SNAP document, the vision and purpose of it was a good example of, these are fantastic ideas, but how do we get the rhetoric into translating into reality? Because for many women that we work with, this isn't the situation. Many of the women we work with experience multiple forms of violence against women. And one consultation we done, 112 women had experienced 515 different forms of male violence. So one woman might experience child sexual abuse, domestic abuse, commercial sexual exploitation, and that added up to 515 cumulatively across the 112 women. Also, this has impacts across women's experience of the life cycle. So they might experience child sexual abuse and then go on to experience domestic abuse. But this isn't about if you have experienced child sexual abuse, you will definitely experience other forms of abuse. But where there's barriers and deprivation and lack of social support, you're more likely to be targeted for further abuse further down the line. But we also have to recognise that the impact can be across the life cycle as well. So we need long-term supportive services. Key to all the work that we do is power dynamic involved, and this model kind of highlights that. And we recognise this as a challenge to attach to the colleagues because they have legal responsibility for protection. particularly where there's children or vulnerable people involved. But we have to increase opportunities for women to have control over their lives and over decision making, which we think is one of the key things that has come out of COVID as well. So for this inquiry, we would say that the health of our community is very much connected to oppression experienced by those communities. And this is shown by the fact that the higher the SIMD communities, the lower the health experiences and mortality rate. For women, their exclusion from decision making and even just research exacerbates this. And as someone said, absence of evidence isn't evidence of absence. And for women, I think this is particularly relevant, but it doesn't stop challenges with policy and legislation. So we have to make sure that women are involved in those decision makings. So for purposes of this inquiry, we would ask that we have an increased participation of women in decision making, and that doesn't mean that women's life experience should be considered, but they should actually be involved in the structures that allow decision making. We would like an immediate inquiry into women's health in general, and not just with COVID, but how COVID's impacted certainly, but across their life cycle and the impact of violence against women. A recognition of violence against women is a form of oppression, and it's created and reinforced by external factors in women's lives. It's not about women's individual vulnerability, but how that's exploited. And you can see that as well. That's essential when we're looking at the factors that have impacted on COVID for women. And finally, clear data collection, moving, for example, in Glasgow, moving away from male violence against women into gender-based violence, confused data and made it difficult to identify where women were experiencing abuse, where men were experiencing abuse, or other members of the community. So we need clear data collection that ensures that we can check on what women's experiences are and how that can be integrated to any decision making that's happening. I'm not sure where I am in my time, but I went as fast as I could. Thank you very much. And if anybody's got any questions, they can come back to me later on, because our contact details are on the slides that you've all received.
Thank you very much, Dawn. Yeah, you did perfect for timing. So, and obviously you had the interruption at the start. So, you know, we'll allow you an extra 10 seconds. Yeah, so I'll leave this up on the screen just while I'm kind of getting the slides sorted, just so people can have it. But we'll make sure that any material in terms of contact for people are available after the event as well. And we'll obviously be able to facilitate contacts and networking for those that would like to speak to certain individuals who have participated today. So next up on the list is Bruce Whyte from Glasgow Centre for Population Health. So Bruce, if you're there, you're ready to take over the slides.
Yeah, thanks, Tony. So I'm going to talk about transport and active travel during the pandemic. And by active travel, I mean walking, cycling and wheeling. But I'm first just going to show you a slide. Which buttons do I get to?
So if you click this screen, you should be able to use the downward arrow or the right arrow on your keyboard. Should be the easiest way.
Oh, no, too far.
Or go up the way to get back.
Okay, that's it. Yeah. Yeah. So just to show you, this is some pre-COVID cycling trends going in and out of Glasgow. You can see a big increase in cycling in Glasgow over the last 10 years. And in fact, pedestrian moving in and out of the city centre increased as well. And the back behind that was increased investment, the next bike scheme, etc. And there's policy context, which is quite supportive. Climate change is clearly the big priority to reduce our carbon emissions, but we're also trying to reduce air pollution, build better neighbourhoods. The National Transport Strategy is trying to achieve a shift to sustainable transport, and there's other policy which is trying to get us more physically active. So maybe not surprisingly, the active travel budget has been going up in recent years, and in fact in the last few weeks has gone up even more. So there's a commitment now from the government to spend £320 million on walking, cycling and wheeling, which is trebling of the budget from where it is just now. So that all is quite good. I'm just going to talk a wee bit about the COVID context now in terms of transport, and this is based on a report I and others were involved in earlier on in the pandemic. So the main messages were that the restrictions from COVID had significant impact on the number of trips people were making and how they made those trips. the most significant being the large and continued reduction in public transport journeys. Car driving also reduced initially, but the levels of car use have now risen steadily since the restrictions have been eased and are now only slightly below pre-COVID levels. Walking and cycling did increase in the early stages of lockdown when we had quite good weather and there was more free time for people and less cars on the road. Have now returned to normal levels. So the impact of the reduced capacity and use of public transport is that there's likely to be reduced transport options for many people, in particular the financial strain for people who don't have access to a car. And the alternatives to using public transport, they can be positive and they can be negative, but overall there are probably more negatives in terms of health and well-being and health inequalities. So looking forward, what we need is a transport system that's affordable, that's accessible, that's sustainable, and which enables safe travel for all ages during the pandemic and beyond. This infographic just illustrates the link between climate change and sustainable transport, and it's not just about building another cycleway. We need to get more people using public transport again, which is currently not the case, and we need to get less cars on the road. So we need to really revolutionise and completely change our transport system. A couple of points just to finish in terms of cycling. Serious cyclist casualties have risen. They're low, but they've risen in Scotland in recent years and in Glasgow. And in about 1 in 10 cases, a collision with a cyclist, the vehicle doesn't stop. And that's the same for pedestrians. So although cycling is not a dangerous activity per se, the perception and the real risk of cycling contributes to low cycling uptake. And there's inequalities in access to cycling and ownership of bikes, particularly in relation to income. And we know that many more men are likely to cycle than women. And I think this is my final slide, just to illustrate some other issues to consider. The speed of implementation of some of the new infrastructure is really very slow. Accessibility and safety for people with limited mobility and visual impairment is certainly an issue for some of the new infrastructure that's been introduced. And it points to the need for meaningful community engagement at a very early stage in these projects. And finally, if we're to achieve a just transition, we need behaviour change approaches that focus on addressing inequalities in access, and that's particularly true for cycling. And I think that's my last slide.
Thank you very much, Bruce. And yeah, thanks for sticking to time as well. This puts the pressure on everybody else that's about to follow as well, that we've been doing so well so far. So I'm sure it'll continue. So next up we have 2 speakers who are going to speak on behalf of Kingsway Community Connections, which are Lainy and Beth. So I'm going to remove the slides just now for Lainy and Beth when they want to present. So Lainy and Beth, over to you if you're there.
Hi Tony, thanks very much. Thanks for inviting us along. We're absolutely delighted to have the opportunity to speak to you all today. Kingsway Community Connections is a community anchor organisation situated at the base of one of 4 high-rise flats in Kingsway Court in Scotstoun. The area is one of Scotland's most deprived, and we host a large number of asylum seekers and refugees. While this makes our community culturally rich, challenges are notwithstanding. We'd like to talk to you today about the unique barriers that exist for people living in high-rise flats. There are thousands of stories from our small area alone that should be heard. Beth is now going to illustrate the individuality of lockdown experience with the stories of just 2 of our residents. Thanks, Amy. Over the past 18 months, some of us may have forgotten exactly what it felt like when Scotland went into lockdown. We appreciate this might be difficult for some of you, but we'd like to take you back there. I know it's difficult doing this over Zoom, but I'd like you to try and ignore any distractions over the next 2 minutes. Close your eyes and take yourself back to the 23rd of March 2020. Remember all the anxiety, fear and confusion over what lockdown meant for you. Remember the logistics involved in doing something as simple as a food shop for your family. Remember the travel restrictions, brand new rules and a shared sense of vulnerability. Now imagine you're 14 floors up in a high-rise flat in Kingsway Court. You're in your 80s, you live with your 2 adult sons and your mobility isn't what it used to be. The lift is being upgraded, meaning there's 1 lift for all 246 flats in the block. You need to walk down 2 flights of stairs just to get the lift, despite your dodgy hip. One day, you're told to stop. You can't go out, you can't go to the shops, and you lose the connection with the outside world that you once loved. And then the unimaginable happens. Your lifelong friend and neighbour suddenly dies of cancer. You're stuck in a flat, in a street in the sky with a head full of sadness. You physically can't leave, and your anxiety wouldn't let you anyway. The depression and anxiety gets worse and worse until you're screaming at your two sons through sheer agitation and frustration. This lady told us that lockdown changed her forever. Remember how you felt on the 23rd of March 2020 and the realisation that you might not see your friends or your parents or your siblings for a long time. Now imagine you're on the 18th floor in Kingsway high-rise with two children under 8. They don't understand why they can't go to school or go to their friend's house for dinner like they used to. They don't understand why you spend hours on the phone to your family each night back home, crying because you don't know when you'll see them again. You can't even explain to them because you've only been in Glasgow for 6 months and your English isn't strong enough. It's not strong enough to translate the confusing, contradictory guidance released by the government, and it's certainly not strong enough to translate into language a child can understand. You're all alone in a place that doesn't feel like home just yet, and you have no idea who can help. As Lainy said, these are just two experiences. Also give a thought to people who lived alone, to the single parents homeschooling, and to those who experience loss. Thanks, Beth. You simply can't discuss health inequalities in Glasgow without considering housing inequalities. As you've just heard, high-rise living compromises people's physical and mental health. This was exacerbated during lockdown. Lockdown was probably a bit more bearable for people living in houses with gardens. All of our residents had limited, or in some cases, no access to outdoor space. It's time to stop saying phrases like the new normal, we're all in this together. For communities like ours, the old normal was hard enough. Why are we happy just to accept that the people we work with and for should bear the additional burden of COVID recovery with reduced levels of support? We should appreciate and react to the unique types and levels of need. Please note the use of the word react in terms of how to react, respond and recover. From COVID, funding and decision-making jump from react to respond, recover, in our opinion, far too quickly. We feel the solution to this is mutual trust between agencies, stronger relationships in the sector, and increased unrestricted funding. While we appreciate the challenging funding landscape, consistent cuts to government funding over the past decade or more has led to greatly reduced capacity within the third sector, despite the significant increase in demand. We feel the money that is available could be better spent through less restrictive monitoring processes, removal of barriers in partnership working, especially in terms of partnership funding bids. If we're going to make a difference, we need the government, both national and local, to trust that community anchored organisations are best placed to understand and react to their community's needs. Thanks for listening.
Thank you very much, both Lainy and Beth. Obviously, it's really important, and one of the reasons why we wanted to do this kind of session is putting the lived experience of people into and linking up with some of that, kind of more data side and other things that, again, getting that combination together, which is really important for the message to come across really powerfully. So thanks again. So next up, we've got Lucy Mulvagh from the Alliance is going to speak. So Lucy, over to you.
Thanks very much, and thanks for the invitation to speak today. I'm going to talk about social care. COVID has really shone a glaring public spotlight on social care, but there were many issues that predate the pandemic, and the Alliance has been calling for a radically different approach for several years. We welcome the Scottish Government's current national consultation on social care reform, including proposals to create a national care service. This follows an independent review of adult social care known as the Feely Review that heard from people who access and deliver social care, including extensive engagement by the Alliance. We believe there are several actions that are crucial to the creation of a new national care service. There's not enough time for me to go into details today, but you can find out more in a briefing paper that we published last week, and Tony's kindly going to put a link in the chat box to that. For today's meeting, I've got time to address two of these actions. The first is about co-production. For many years, people and organisations have shared their experiences and views about what needs to change in Scotland's social care system. The Alliance has contributed with a joint research project called My Support, My Choice. This is the largest national study about people's pre-pandemic experiences of social care across Scotland. We've published several reports, including one about people's experiences in Glasgow, and a link to these will also be put in the chat box. The information that people and organisations have provided over the years is invaluable in helping inform change. However, people's participation in decision-making is also essential, and this goes beyond consultation. The Alliance believes that social care reform should be co-produced to ensure that people and organisations are involved as equal decision makers with an equal seat at the table, alongside public bodies like the Scottish Government, local government, health and integration boards. Putting people in the third sector at the heart of decision making makes good business sense because it gives decisions greater credibility and promotes sustainable implementation. The second action I'd like to address is investment in social care. Increased and adequate funding for social care is urgently needed. Without proper resourcing, social care cannot reach its full potential. People will not have access to good quality support, and the workforce will not benefit from fair work. The Women's Budget Group notes that investment of 1% of GDP in the care sector would produce 2.7 times as many jobs in the economy overall as an equivalent investment in construction. It's welcome that the Scottish Government has recognised that human rights should be at the heart of social care, and that social care is an investment in Scotland's economy, people and society. It is committed to increase funding by 25% and at least £800 million more funding over the course of this Parliament. However, the Feely Review estimated that its recommendations would cost an additional £0.66 billion per year, or approximately 0.4% of Scottish GDP. It noted that increased expenditure is essential to achieve a rights-based system and will have a positive impact, amongst others, on women's employment and the gender care gap, because, as we know, social care is a highly gendered issue and 87% of the workforce are women. The final point I'd like to make is about human rights budgeting. The Feely Review recommended careful consideration of options for raising new revenues to increase investment in adult social care support. The way public bodies raise and spend money is an indication of what they value. Therefore, if human rights are valued, they should be considered as budgets are developed. However, human rights and budgets are often discussed separately. The Alliance believes that taking a human rights-based approach to social care budgeting would embed fairness, transparency, and people's participation in decision-making about resource generation, allocation, spend, monitoring, and accountability. Thank you very much.
Thank you very much, Lucy. And again, another one to thank for sticking to time as well. So next up, it will be Catherine Skivington, who's coming from the University of Glasgow, and I'll just get the slides up so we can make a start with that.
Hi everyone, thanks very much. So I'm going to focus on how COVID has affected our social relationships. So a team of researchers from my department, the Social and Public Health Sciences Unit at the University of Glasgow, work on a programme of research around relationships and health. And lately we've been writing about some of the relational mechanisms that are important to health and well-being that have also been disrupted by the pandemic. So in a recent paper, we talk about social networks, social support, norms of interaction and intimacy, which have all been disrupted in different ways and differently for different people. And obviously I don't have time to focus on all of these things just now, but but I want to emphasise the impact that the, albeit necessary, measures to restrict physical contact has had on our social lives, and highlight that there are various challenges and opportunities going forward, and not least related to social connectedness. So we know that social connections have many benefits for health, and that loneliness and social isolation are associated with lower quality of life and have increased risk for morbidity and mortality. They're also socially patterned in that social isolation and loneliness are more common among people who are more socio-economically disadvantaged. So from the very start of the pandemic, the equating physical distance with social distance was regrettable in the term social distancing, since only physical proximity causes viral transmission, whereas many forms of social proximity are obviously crucial to maintaining relationships supportive of health and well-being. Opportunities for spontaneous social interaction were curbed by the closure of venues and shift to home working, which limited options to receive social support from people outside of one's social core network. So the opportunity to interact online has been taken by many, and I'm going to focus on the associated implications and challenges of that. So there are many opportunities that we should embrace and work out how best to develop further. For example, online connection offers the possibility for support and socialising for those who are unable to access in-person services, for example, because of mobility issues or because people are geographically isolated from their support community. It also offers many of us the possibility to work flexibly and greater opportunity for learning. Possibly the biggest relevant issue here is the shift to online is the existence of digital inequalities, which potentially exacerbate existing inequalities. there's unequal access to technology and the internet, and there are inequalities in relation to skills, confidence, and motivation to engage online. The issue of digital inequality is particularly pertinent in Glasgow. So although this table is pre-pandemic data, it shows the results from a survey with just under 4,000 respondents from 15 socio-economically deprived communities in Glasgow. So you can see that internet access among people with a long-standing health condition or disability was only 46%, that a large majority of people living in households with only people over age 65 did not use the internet, and only 35% of working age people who are not in employment use the internet in these communities. And given that job searching and applications are largely online, this figure is particularly stark. Some more recent estimates of digital inequalities show that it's clear that effort needs to be continued in improving digital inclusion. And there's obviously been some positive effort prompted by the pandemic to tackle the digital divide. For example, through the Scottish Government's Connecting Scotland programme to get people online, and in the Welcome digital strategy published earlier this year. It will be essential to monitor progress on this strategy, and particularly at a local level, to make sure that communities have the opportunity to be more involved in identifying their own relevant needs and solutions going forward. And this largely echoes what Lucy's points were about participation in decision making. Also, research evidence shows that online social contact, particularly for older people, is unlikely to compensate for social inequalities, and also shows that it's unlikely that remote technology provides an effective substitute for in-person interaction. So COVID restrictions have had different impacts on relationships, and often most negatively impacting those who already occupy the most socio-economically disadvantaged positions in society. So we need to balance online and offline interactions alongside building stronger and more sustainable local communities. Thank you.
Thank you very much, Catherine. And so next up, we have Leslie Morrison from MEDAC. So I'll probably stop sharing the screens because I don't think Leslie was using any slides for this. So Leslie, over to you.
Yeah, thank you, and thank you for inviting me. I'm a retired GP. I'm coordinator of MEDACT in Scotland. MEDACT's an organisation of health professionals working for a better, fairer, safer world, which I know is what everybody here is doing as well. There's a lot of work to be done, so the more the merrier. And we have been, a lot of our work focuses on the interconnections between peace and disarmament, peace and the climate crisis. The climate crisis is obviously a health crisis. Bruce spoke a lot about that in in describing his work around healthy public transport. Kat spoke about opportunities out of the COVID crisis, and we've been doing a lot of work in the health community, looking at the lessons learned from the COVID crisis that are applicable to the climate crisis. In summary, neither COVID nor climate, the results of either of those crises, pay any attention to borders. In both cases, prevention is better than cure. That in both cases, we need to value the science. We need to look at the data that people are presenting here. We need to take it seriously, and we need to translate it into action. And as many people have said, we're only as safe as the most vulnerable. That applies to COVID, any future pandemic, of which there will be several, and climate. And very importantly, that such global challenges require systemic change. And I think everybody here would agree with that. A subgroup of MEDACT in Scotland is Health for a Green New Deal. And that's a group of health professionals. Many of them are GPs, often young GPs in Glasgow, but throughout the country, throughout Scotland, looking at how we achieve a just transition, how we think global and act local. And a lot of our work is around jobs, as Lucy was referring to, and how that just transition needs to address people's need for good, healthy jobs. We're planning various activities around the COP. We want to have a health presence. We want to take opportunities, and we've got various ideas which we'll be publicising soon around making that connection, that the health the climate crisis is a health crisis, and we are working towards that, and as I say, having a presence at the COP. So if anybody would like any further information about the work of MEDACT, or can see ways in which we can collaborate and work together, we would be absolutely delighted to do it. We have doctors, the majority of our members are doctors, we have nurses, auxiliaries, occupational therapists, a whole range of health professionals are members of our national organisation. Please look at our website, medact.org. Thank you very much.
Thank you very much, Leslie. And so next up, we have Michael Roy from Glasgow Caledonia University who's going to present. And Michael, I don't think you had any slides either, so I'll just leave it as is. So
I didn't, Tony. Thank you very much indeed. Hi everyone, I'm Michael Roy. I'm a sociologist and a professor at the Eunice Centre of Social Business and Health at Glasgow Caledonian. I'm going to talk very quickly. And I want to thank the People's Health Movement today for the opportunity to give evidence today at this inquiry, particularly alongside people I hold in such high esteem. So the Eunice Centre has been going for about 10 years now. We're one of the largest and most important research centres of our type internationally. I actually lead the social economy research group there. So we research values-led and solidarity-based organisations. I'm particularly interested in the impacts of such organisations, particularly on the health and well-being of individuals and communities, through acting on the social determinants of health, such as poverty, inequality, social inclusion, education. We consider that such organisations in civil society to be what we call non-obvious providers of public health. They're non-obvious in that they exist outside of what we might consider as formal public health systems. So I suppose my main message today is we somehow need to convince policymakers to better recognise and support the impact of those in civil society doing vital work in our communities who have clearly delivered on health and wellbeing benefits. Such organisations work to keep the fabric of our communities as intact as best they can, often with very limited resources, and very often resources that have been severely affected due to austerity over many years. So we need to work out better how to support and recognise their upstream impact in public health terms, rather than focusing almost exclusively on downstream services aimed at fixing people after they've gotten ill, albeit I recognise that's important as well. We've also been contributing to ideas that have emerged recently, particularly such as wellbeing economy or inclusive growth. I think it's incumbent on researchers to do so, to engage with such policy agendas, and it's especially important in the context of what Kat was saying in terms of new opportunities and spaces for emerging policy conversations on the role of and purpose of the economy, the intrinsic connections between how we organise the economy and our health and wellbeing. Some of you might be aware of our recent research. So we had a 5-year project called Common Health, which is looking into the health and wellbeing impacts of social enterprises, or our recent work in the health impacts of men's sheds, which got a fair bit of attention. We've got 2 projects on the go just now that have relevance to today's discussions. First of all, I led a rapid response COVID project focusing on the various mutual aid groups that emerged spontaneously during the COVID-19 lockdown. This was funded by the Chief Scientist Office of the Scottish Government, focused on the extent to which they complemented and enhanced more formal efforts to address real gaps in provision that emerged during lockdown last year, particularly as local government took a fair while to address gaps in some places, and existing charities are stretched and trying to pivot themselves in places. We found that community response was remarkable. They were able to support the resilience of communities. They worked extremely effectively in those areas hit hardest by the pandemic. And while mutual aid is often considered to have been rooted in the anarchist philosophy, we found that we're not explicitly antagonistic towards the state or charities, well, at least not all of the time anyway. We've also got a new major 4-year project called Common Health Assets. It's funded by the NIHR. It's a realist and economic evaluation of the role in community-led and owned organisations in health and wellbeing of participants, working with a range of partners across the UK. It started just a couple of weeks ago. It was delayed due to COVID. We're working closely with a small bunch of the former healthy living centres in Scotland, so Annex Communities in Partick, for instance. And those that know them and know how organised they are, know they do wonderful stuff in some of our most deprived communities, delivering, for example, innovative social prescribing models on behalf of the NHS. Finally, I just wanted to say that I totally reinforce and agree with the recommendations by my colleagues, for example, at Kingsway Community Connections, and for what Lucy from the Alliance is saying in terms of co-production. I think we owe so much to partners in civil society for supporting us through this pandemic and supporting others to recover and reconnect with people after a period of profound social isolation. So if you're interested or you want to reach out, you're interested in learning more, I'm very easy to find on Google. So thanks very much indeed for listening.
Thanks, Michael. I hope for all the best reasons you're easily accessible on Google. But, So next up, we have Jan Mccloud from the Women's Support Project. So Jan, over to you.
Hi, thanks very much. Yeah, my name's Jan Mccloud. I work at the Women's Support Project. We work on issues around violence against women, working at local and national level. And in terms of the impact of COVID on health inequalities, I'm going to base my comments really on our experience of working to highlight the needs and experiences of two, I suppose, like very different areas of work, different groups of women. The first is in relation to commercial sexual exploitation, women who sell or exchange sex, where we've been involved in work on that in that area in conjunction with the Encompass network, which is frontline services supporting people in prostitution. And the second area was in relation to the needs of migrant, asylum and refugee-seeking women who use our Rights and Choices project, which is based in Glasgow. What I've got to say really is quite similar to some points that have already been made in terms of the pandemic really highlighting pre-existing inequalities and also exacerbating these problems that you can see as a widening of equality gaps. In relation to commercial sexual exploitation, the single main reason why women enter the sex industry is poverty. It's not so much a free choice as a lack of other viable options. And women commonly speak about things like health issues and childcare needs being barriers to the job market and leaving them no other options for supporting themselves and their family. There's ample evidence to show that involvement in the sex industry has got a negative impact on physical and mental health and leads very often to increased drug and alcohol use as a means of coping with the unwanted sex. So at the start of the pandemic, women involved in selling or exchanging sex faced an immediate loss in income. And although it's not an offence to sell sex in private, women found themselves in a situation where there was no access to government support schemes and, like everybody else, great delays in being able to access help through the benefit system. Women reported that their main concerns were like money for essentials to support themselves and their families, followed by mental well-being, housing and safety concerns. And by November 2020, 67% of the women who responded to a survey said that they'd had to access crisis funds just to meet their basic needs. In relation to the refugee and asylum seeking women who use our Rights and Choices project, the number one need from the start of lockdown was food poverty, followed by fuel poverty, and also the impact of poor housing, whether it was housing where they felt unsafe because of the physical condition or because of racist harassment or because of conditions of temporary accommodation, or whether the accommodation was insecure. Women very often faced constant moves. It was very difficult to settle. All of that added to the mental health impact. And the impact of the expensive travel costs in Glasgow, somebody just mentioned it as well, really adds to the fuel poverty. Women can't afford to get on a bus and go to a cheaper shop because the bus fares rule out the advantage that you get there. So both these groups of women reported a marked increase in stress, anxiety and isolation, and an overarching problem, especially for refugee and asylum seeking communities, with digital poverty, without which we're severely disadvantaged not only in claiming benefits, but in getting access to information. So for the future, looking at the bigger picture, we'd really like to see like gender sensitive universal income. We need to address the wider economic abuse, the structures that prevent women having economic independence, as well as the financial abuse that women often face as part of domestic abuse or within controlling family relationships. We need to have realistic and flexible working conditions and affordable childcare to allow women again to have that economic independence. Wi-Fi, I think, is essential, and Wi-Fi as standard and temporary accommodation would make a massive difference to individuals. And just a final point, I think, is that we're looking for councils and health boards and services and others to really invest in engagement work and to try and find ways of amplifying the voices of excluded and vulnerable groups, and to resource communities to be able to engage with that work. Because I think the best way forward, without a doubt, is to work together to inform policy and service development so that people are involved all the way through. Thanks very much.
Thanks very much, Jen. And then next up, we have David Walsh from Glasgow Centre for Population Health. And so I'll just get the slides ready for David.
I just check it. I've got control before you start your clock.
You should have control if you.
Okay. So this is for my 4 minutes of fame then, and the point I want to make is that the blurb for today's event talked about health and inequalities since the start of the pandemic and looking towards the future, as a few people, including Kat and Gerry, have mentioned. Clearly, to understand current and future inequalities, we really have to understand what was happening prior to the pandemic. And in Glasgow, poor health and wide inequalities have been shaped by a whole series of historical and especially political factors. Before I get into all that, the first really important question is why, there's no mystery why there's poor health in Glasgow. It's because there is lots and lots of poverty. As this audience knows, poverty is the main driver of poor health in any society, be that Glasgow, be that anywhere else on the planet. And indeed, if you plot a different measure of poverty alongside a measure of how long people on average live, and you've traced that line down the middle of the chart of the main UK towns and cities, you see the tragic truth that the greater the level of poverty in society, the younger on average people will die. That is also the case for Glasgow, but the city is also an outlier in terms of having worse health than that socio-economic profile, as we measure these things, would predict. And previous work we've published has shown that that can be attributed to a whole series of what you might call unfortunate historic events. And these include much worse living conditions historically in comparison with otherwise similar places like Liverpool or Manchester in England. It includes responses from local government in Glasgow over the post-war decades, which in effect made a lot of things worse in terms of breaking up existing communities, building really poor quality peripheral housing schemes on a much larger scale than anywhere else, and fundamentally investing less money in looking after properties, meaning that, again, people in the city were living in much worse conditions. It also includes responses in the same time by the Scottish office of the UK government, who basically gave up on Glasgow at the time, designating the city to be a declining city and moving investment and industry away from the city. And that included a socially selective migration policy whereby only the inverted commas best families were able to move to new housing outside the city, leaving very high proportions of the old, the poor and the sick, and therefore the vulnerable within the city boundaries. And I've now lost control, Tony. There we go. On top of all that, by the time we got to the 1980s, there's a lot of evidence that other cities dealt better with the challenges of the Thatcher government era, whose policies were obviously widening inequalities across Britain, in terms of looking after the needs of the poor. So, for example, here, in terms of building better and more affordable council housing in other cities. All of these things, my slides are not moving forward. All of these slides, things are things that we included in a publication a few years ago, but since then, if you click again, Tony, if you've got this, We've seen further events in terms of a huge economic recession in the late 2000s. And then after that, of course, the UK government's response to that in terms of their austerity agenda that's already been alluded to. And that has had a calamitous effect on health and health inequalities, not just in Glasgow, but across Britain. Tony, can you click on if you've got this? And again, and I'm not entirely sure how much of the general public are aware in terms of the impact of slashing income of the most vulnerable has seen increasing death rates among the most deprived populations everywhere. And then within Glasgow, if you click again, Tony, we've seen a dramatic reversal of previously falling mortality rates among the most deprived sections of the population, and thereby a widening of inequalities. And so it's no real surprise that then, and you can click on again, Tony, by the time we got to the next historical event in terms of the pandemic, we've seen this scale of COVID inequalities that others have alluded to. And the real worrying thing then, if you click again, is what lies around the corner in terms of, are there going to be further economic shocks, a return to austerity? What's the impact of Brexit going to be? How are these things going to interact? So to conclude my 4 minutes just with 4 points, what's happened in Glasgow, I think, has been less a series of unfortunate events and more a series of really, really, really shit events. And given that, I think it's hardly a surprise that we see poor health and wide inequalities in the city. But the really important point is that you have to understand those historical factors to understand current inequalities and the likely trajectories of future inequalities. As a final point, the media refers to this excess level of poor health as a Glasgow effect. The evidence we've published shows there's no such thing as a Glasgow effect. What there is a political effect, and importantly, therefore, it requires political solutions. If you just click one last time, I'll just conclude by saying, there you go, 7 decades in 4 minutes. If you want any information on any of those decades, feel free to get in touch. Thanks.
Thanks very much, David, and thanks for persisting with the technical difficulties. So it was bound to happen at some point, so we just waited for the most complex presentation to do it in. So next up, we've got Gay Mccloud from Gale and Enough Scotland presenting. Over to you again.
Thanks, Tony. And I'm here with my colleague Dorothy from Gale. So we're sitting around the table in our new outdoor shelter. So I've got two hats. So first of all, Enough Scotland. So we're a degrowth and decolonisation collective working on those themes. People might be more familiar with the degrowth term from academic circles as a planned reduction of energy use and resource use to rebalance the economy, to deal with inequality and increase well-being and respond to the climate crisis. But we're particularly interested in taking that out with the academic circles and looking at the cultural implications of exploring degrowth and what that means in terms of producing and consuming differently. And I think that's how it relates to our work here at the Gale, where we work alongside people. We produce together, we consume meals together around this table that we're sitting at just now. We discussed these themes together last week to bring to the People's Health Inquiry today. But I really wanted to pass over to Dorothy to speak a little bit more about some of the first-hand experience of people who were experiencing considerable health inequalities pre-pandemic and how the pandemic impacted them. So I'm going to pass over to Dorothy.
So our participants and volunteers really reported an exacerbation of existing inequalities as a result of the impact of austerity and a hostile environment for benefits claimants. So some people spoke about the challenges of high-rise living, and I think the Kingsway connection spoke well about that. I'll say no more about that. Other big issue that came up for our participants and volunteers was mental health, trauma and addiction relapse in the early stages of the pandemic. Many had felt that they were discharged too early from mental health, trauma and addiction services and felt really at sea when the pandemic hit and they were experiencing relapse. Another aspect was many people experiencing loneliness and isolation. So digital exclusion early on in the pandemic certainly exacerbated their ability to connect with others and fulfilling roles that they might have had here. Another issue that people were deeply, lots of anxiety around our department and working health assessments. Many telephone assessments took place right away again. I'll give you an example of a 64-year-old man who had his first tenancy in his life just for 5 years after long-term homelessness, a lifetime of addiction and trauma and unemployment, and put through a telephone assessment without access to his wider support during the pandemic, and was appalled, and the lack of dignity that people experiencing that really came through strongly. Another issue, we support long-term prisoners who didn't have access to visitors, home leaves, work, gym, and really difficult experience for long-term prisoners preparing to leave. And I think that's my time up.
But thanks very much. We've been very glad to be able to participate in today's inquiry.
Thank you both. So I know you did have some slides, and there was pictures. I don't know if you want me to quickly go through them. We've got a wee bit of time. There's 30 seconds or so.
Yeah, I almost wished I hadn't put in slides seeing but this will give you a wee idea of the communities that we work with. And yeah, a favourite quote to finish on. Thanks.
Thank you very much, both. So next up, we have Nicola Burns from University of Glasgow as well, presenting about the Scotland and Lockdown project. So Nicola, over to you, and I'll give you the remote control for the slides as well in a second.
Okay, thanks very much, Tony. So thank you to the People's Health Movement for this invite to provide evidence to this People's Health Inquiry. As Tony said, my name's Nicola Burns, and I was a co-lead on the Disability and Health Conditions workstream of the Scotland in Lockdown Project Research Collective. Tony, I'm afraid I don't think it's working, so if you could maybe just do the honours, thank you. Okay, so this piece of work was funded by the Chief Scientist's Office. It took place between July and October of last year, and it included working with 20 third sector and community organisations. And really its purpose was to try and understand the challenges faced by groups already isolated pre-pandemic. That included refugees, people seeking asylum, people in prison, people experiencing domestic abuse and sexual violence, people with a long-term condition or disabled. And today I'm going to focus on one group. I'm going to focus on disabled people, but if you'd like more information about the project, please do have a look at our website. If you could go to the next slide. So overall, our study found very much similar to what other people have been saying, that the pandemic really revealed and reinforced lines of exclusion and inequality, rather than necessarily creating new forms of exclusion within that 6 months. Just under half of the participants for our group around disability lived in Glasgow. Often, disability can be understood as a health issue, but to do so misses the structural, environmental and attitudinal barriers encountered by disabled people in their day-to-day lives, which produce the inequalities, including health inequalities, faced by this group in Scottish society. Pre-pandemic, the impact of austerity policy on the lives of disabled people, both in its material effects, almost a third of disabled people in Scotland live in poverty, and in the provision of services such as social care to enable people to live independent lives. In this context, the ability to maintain health and well-being has been impacted and exacerbated by established health inequalities arising from these structural barriers within healthcare systems. And that really picks up on something that David had said, that we need to look to the inequalities that were already there. So some of the things that we found out in relation to these health inequalities, first of all, challenges facing people in trying to access care settings during the pandemic due to COVID modifications, a reluctance to actually contact services due to concern over risk of the virus and perception of that heightened risk. Also, an acknowledgement of the issues that we're facing, the health system itself, and not wanting to bother anybody. People said that there was variability in access, that there was these physical risk issues, but also that as the pandemic continued, there's been delayed access to specialist services. And this in itself was a cause for concern for many people, as they were worried about maintaining their health, maintaining their well-being. Other issues that were discussed was also the issue of do not resuscitate orders being used, or the suggestion of them being used within the healthcare system. Tony, the next slide, please. In terms of maintaining health and well-being, it's more than just about acute health services. Isolation and loneliness increased, including and impacting on physical and mental health. Social care services were significantly reduced or withdrawn, as we heard from Lucy. There was also an issue of digital exclusion. Glasgow Disability Alliance estimate that around 60% of their members have no digital connections. And the management of risks, such as shielding letters arriving, other people voluntarily shielding because of confusion over the lack of accessible information, what conflicting information that people were receiving. If you could go to the final slide, Tony, thanks. So in terms of thinking about these pandemic futures, I've given a quote here from one of our participants saying, you know, I genuinely feel like disabled people have been abandoned, forgotten about, and left to try and survive as best as they possibly can. And so, given that Glasgow's population includes a greater proportion of working age disabled people than many of the commensurate cities, any endeavour to address health inequalities in the city must include and acknowledge the needs of this group. As society returns to normal, many of the issues raised will be exacerbated for disabled people. Concern over the reduction in social distancing, heightened risk around health appointments, the reduction of social personal care. The pandemic saw the reduction in social care services across the city, and this has had profound implications on the ability of disabled people to maintain their health and well-being. People worry that there will be, in fact, a permanent issue as the financial impact of the pandemic begins to take effect. And Lucy talked about the Feely review, so I won't talk about that. From a policy perspective, what can we think about? We need to think about actually following that commitment to the Convention for the Rights of the People with Disabilities, place human rights at the starting point for addressing the needs of disabled people, recognising that health is a human right. And following from that, we have to actually involve disabled people. They should be actively involved in the shaping of social care in the city. And while our research pointed to the grave situation that disabled people faced, it also highlighted the work of organisations, mutual aid organisations such as Glasgow Disability Alliance, in addressing these immediate needs.
Thanks very much, Nicola. Apologies for the technical issues there, but we managed to get through. That's okay. So next up, we have Scott Donohoe from Scottish Hazards, and I'll stop sharing the screen because I don't think there's any slides from Scott. So Scott, over to you when you're ready. You're on mute, Scott.
Sorry, my apologies, that pesky mute button. Thanks, Neil. I'm just going to give you a whistle-stop tour from a worker's perspective about what happened during the pandemic. So I've got quite a lot here, but I'm conscious of time, so I'll cut right through it. In terms of Scottish Hazards and the trade union movement, obviously when the pandemic kicked in, we had to react very quickly to it. We were meeting weekly, sometimes daily, with Scottish Government and other bodies around our future strategy and approach to it. We had to set up online training for a lot of our activists, stewards and trade union safety reps. In terms of initial issues, obviously it was the issue of PPE or lack of it. Many of our members having to go into care homes and indeed their home helps going into homes without the appropriate personal protective equipment, therefore putting themselves at risk. The issue of care home admissions was a massive mistake. There's no doubt that will come out in the other public inquiries to follow. Huge issues around statutory sick pay when a lot of our members were off sick, weren't getting paid properly. In terms of our members' issues, long COVID, we have many of our members have been off long term with long COVID and the associated issues, particularly in residential care homes in the city, and obviously our home helps. Big increase in psychological issues, anxiety and depression. Some of our members showing significant suicidal ideation. Some members being dismissed on capability grounds due to ill health, due to actually catching COVID as a result of their work. And big problems with occupational health provision around reports in terms of the absence stuff. In terms of our activists, I say trade union reps who were doing a lot of the work. Again, their workload went through the roof because we were having to review a lot of workplace risk assessments, both for groups of workers and for individual people, for particular people who were shielding, had underlying health problems, and so on. A massive risk assessment framework was set up that we had to go through for vulnerable workers, parents, carers of children, and some of the absence policy stuff as well. In terms of issues with some of the employers we dealt with, lack of proper risk assessments, infection control measures, lack of PPEs, I've said, social distancing, education, social work and health, massive issues. A lot of it around some poor management decisions and lack of training, instruction and supervision. Now in Glasgow, we obviously had a lot of meetings with the council around providing proper cleaning provision, and managed to get a 46% increase in cleaners, but that was only because a lot of the cleaners had been cut as a lack of, as a result of cuts to public sector budgets. Individual risk assessments.
Jan was telling me
absolutely stunning.
1 minute.
I'm trying to put some photos up and.
Okay, sorry, I'm gonna right. Okay, right. See you later. And so, okay, sorry to conclude then. Sorry, I've been cut off twice. In terms of our demands, we would like to see obviously a national response to long COVID issues, proper enforcement and resources, a national occupational health service delivered through the NHS, proper plan and resource to tackle equality and poverty within the city, and full implementation of the Fair Work framework. So apologies for that. Somebody else has just come into my office and cut me off as well. So anyway, thank you.
Cheers, Scott. Thanks a lot. And so next up, we've got Mike Downham, who is from Zero COVID. So Mike, over to you when you're ready. So just unmute Mike.
There we are.
Yep.
Sorry.
Right, take it away.
Okay, many thanks for this opportunity. Can you hear me now?
Yep, perfect.
Yep.
Many thanks for this opportunity to speak to you. The epidemic in Scotland is out of control, but it's entirely possible to control it by eliminating the virus. Scotland has the capacity to do it. It's a well-recognised public health method using a combination of vaccines, test, trace, isolate, and measures and messaging focusing on airborne transmission. It's been done successfully by other countries. COVID deaths per population have been less than 5% of Scotland's in Japan, South Korea, Australia, New Zealand, Singapore, China, Taiwan, and Vietnam. That we now have vaccines is wonderful, but relying entirely on them without other public health measures won't work. They are less than 100% effective. Some people choose not to be vaccinated, and the immunity given by the vaccines wanes over time. Worse still is that allowing the virus to spread increases the risk that a variant will emerge even worse than the ones we have already, a variant which might outflank the immunity resulting from either vaccination or catching the virus. But the new Scottish Government hasn't listened. Instead, it's tailed Westminster and let the virus rip in the deeply flawed idea that herd immunity is achievable by vaccination alone. So earlier this month, the Zero COVID Scotland campaign changed tack, gave up hitting its head against the walls of Holyrood, and lined up 40 witnesses to describe at a public hearing how the epidemic has impacted on them. We heard witness statements from carers, nurses, teachers, people suffering from long COVID, people whose children are suffering from long COVID, young people struggling to find work, and people supporting marginalised groups. One of the most compelling statements came from a home care provider who works for Glasgow City Council. She described how she'd been working in the job for 21 years, how the last 18 months have been the most stressful in her working life, how she and her colleagues had no training to help them understand the virus, her managers also ignorant about what they were dealing with, how she tried to stick to doing her best for her clients and at the same time keep herself safe, her clients safe and her family safe, all the more difficult by the fact that some of the homes she works in are not exactly hygienic. At the start, she was told she didn't need to wear PPE unless COVID had been proved, but of course she was often in the home of a client who later tested positive. One of her colleagues whose husband had COVID was told she should go to work anyway. Sometimes she discovered a client she'd visited had already tested positive, but the result hadn't been given to her. There was extra work to do with cleaning and getting in food and medicines for clients whose usual support systems had been stopped by lockdown. Extra work, but not extra pay, in one of the lowest paid yet most essential jobs in our society. When shops and cafes were shut down so she could no longer use their toilets in breaks, she was forced to pee behind bus shelters. It was inevitable that she soon caught the virus. She was off work for 4 weeks, feeling guilty that she was letting down her overworked colleagues and her under-supported clients. Staffing levels have continued to be grossly inadequate and are now at crisis point. The public hearing made it clear that what we're seeing now is key services in care, health and education breaking down through a combination of rampant COVID infection and staff absent with COVID or isolating. Most shockingly, hospitals have become unsafe. Nurses are working despite being close contacts because someone has to look after the patients. They have no time to get tested if they develop symptoms. We've never experienced unsafe hospitals since the NHS began, apart from a few localised scandals. Our governments are increasingly telling us that we should get used to living with COVID like we've got used to living with flu. But we only got used to living with flu in the context of safe hospitals. Thank you. If you'd like to get in touch with the Zero COVID Scotland campaign, I'll put our contact email address in the chat.
Thank you very much, Mike. And so next up, we were hoping to have Jennifer Robertson from the Glasgow Social Enterprise Network and the Wellbeing Economy Alliance for Scotland talking to us, but unfortunately she got called away just before the event started today. So I'll put something in the chat that Jennifer asked me to share, a report around social enterprise in Glasgow in the context of COVID-19. So people will have that if they want to kind of have a look at. We'll have access to that report that Jennifer was hoping to discuss, basically. And then our final one, again, isn't going to be someone who's live with us today. So Amelia Hanna from the Environmental Rights Centre for Scotland, again, was hoping to present, but unfortunately it had a bit of a clash with one of their AGMs that they were having today. So I'm going to share a video that Amelia had recorded for us, essentially doing the same idea of the presentation. And I'll kind of share that with everybody. We can watch for the 4 minutes or so. So I'll just get that loaded and then we can watch that, and then we'll be moving on to the policy responses session for us today. So. Let's get it sorted. So hopefully people can see Amelia's video and can hear the audio when it starts. The audio doesn't seem to be working. As expected, technical difficulties with this video. So 2 seconds, I'll see if I can. If not, we'll move on to the policy responses if I can't get it sorted. So.
Emilia Hanna, and I work. Hello to the Glasgow People's Health Inquiry. I'm Emilia Hanna, and I work for the Environmental Rights Centre for Scotland. And I'm going to talk about the new Human Rights Act that's coming to Scotland and what this could mean for the environment and for health. I'm going to make 3 key points, so let's get cracking. Firstly, a new Human Rights Act is coming to Scotland. The government will consult for a new human rights bill in the coming year, and this bill will see a range of human rights incorporated for the first time in Scots law. Crucially for the environment, it will see for the first time the substantive human right to a healthy environment guaranteed as part of our law, and a healthy environment will be defined according to 6 key features: clean air, a safe climate, safe water and adequate sanitation, healthy and sustainably produced food, non-toxic environments in which to live, work, study and play, and healthy biodiversity and ecosystems. So that's good news. Now, the second point that I want to make is quite an obvious one, but it's an important one. A healthier environment could go a long way to tackling health inequalities. COVID has reminded us of how important a healthy environment is to our physical and mental health. But it's also exposed existing environmental injustice in Scotland. People living in areas of highest deprivation often experience worse environmental quality, for example, less access to high quality green space. It's also the case that socially disadvantaged people, children, the elderly, and people with health conditions are more negatively impacted by environmental health hazards. And we can see this really clearly in Scotland with the example of air pollution. It impacts on all of our health, but it has disproportionate impacts on people with pre-existing lung and heart conditions, on unborn babies, and on children with asthma. So a healthy environment has everything to do with tackling health inequalities. The third point, and crucially, for a human right to a healthy environment to actually make a difference and lead to a healthier environment and therefore to tackle health inequalities in Scotland, it has to be articulated in a strong way, so with teeth. And by this, what I mean is a few different things. It needs to place a duty on the government and relevant non-state actors to comply with the right at all times and across all areas of policy. It needs to give us, the public, the rights holders, the ability to hold the government and relevant non-state actors to account if the human right to a healthy environment is breached. And this is just the obvious point that the law is only any good, it's only any use if we can enforce it in practice. So we need to have access to a low-cost court or tribunal to uphold our rights. And thirdly, we need proper remedies for when our right to a healthy environment is breached. Under the status quo, we as the public can do almost nothing to use the law to stop or challenge developments or projects that are damaging to the environment from going ahead. And that has got to change. We believe that if articulated correctly, the threat of litigation on the human right to a healthy environment could go a long way towards ensuring that the government and relevant non-state actors would think twice about policy decisions and new developments that had adverse impacts on the environment and on our health. In this way, the human right to a healthy environment has the potential to transform policy. It could put the need for a healthy environment much higher in the pecking order when it comes to policy and decision making. But there's a lot of work to be done on the new Human Rights Act. Get involved with it and stay in touch with the Environmental Rights Centre for Scotland. You can hop onto our website at www.ercs.scot. Thank you so much for listening. I hope that has been relevant to the Glasgow context, and I hope that you have a great day. Cheers.
Okay, so that was the last of the evidence submissions for today. So now I'm going to hand over to my colleague Mark, who's going to chair the response section for the rest of this afternoon. So over to you, Mark, when you're ready.
Thanks very much, Tony. Thanks to all the contributors and everyone who's taken time to take part in today's event. We're on to what might be seen as one of the more challenging areas of it, and the respondents that we have been kind enough to come along today. We had asked a large selection of councillors and representatives from across Glasgow City Council to take part in the event, but we didn't get any response. So we will have the councillor Wardrop here who's going to respond to us. But first of all, we're going to have Morag Trainer, who's been sharing some very interesting research in the chat. So I'd like to ask Morag to come in and start her response. Thank you.
Hi there, thanks very much for inviting me here today. I'm going to speak quickly because I have 4 minutes, and I was just going to start speaking in hope that I would reach 4 minutes, but after Tony's military style precision here, I've actually set a timer on my phone so that Tony doesn't get cross with me. There's several things I'd like to say in response. First of all, thanks for all the contributions. It's been really fascinating. Some of these things were new to me, and some chime with other experiences and research I'm having with both my hats on. My hat today is Deputy Chair of the Statutory Poverty and Inequality Commission. We have a statutory duty to advise and scrutinise government action on poverty and inequality. And some of you will know me with my other hat on, which is a Professor of Poverty and Inequality at Heriot-Watt University, and I also conduct research. First of all, what I'd like to say is there's an event I'm speaking at tomorrow for 15 minutes where I will expand on some of the things that I'm going to respond to here, because they very much relate to what you're talking about. It's about what can the policy response be. There's several things, 3 ways to look at this. We need to look at the policies that used to be in place, which are no longer in place, and which have resulted in austerity and increased poverty. We need to look at the things that are currently harming people, those policies that we need a big red stop button that we push, and then we also need to implement some new policies with a big green go button. And first of all, obviously we're with this dual political system of Scotland being located within the United Kingdom. So there's some things that Scotland doesn't have power over, but we're constantly being told we don't have power over that. But actually Scotland has a lot of political and policy power that it's not currently exercising. And I think we saw at the start of the pandemic that Scotland responded, the Scottish Government responded with a scale and a pace and a level of activity that was unprecedented, and it shows that that type of action can be taken. For too long, we've been told that action in certain areas could not be taken because it wouldn't be within the time frame, or we don't have the money, we don't have the skills, we don't have the data, we need to collate this, that and the next thing. But actually when push came to shove, action was taken, and it's absolutely imperative that the Scottish Government maintains that scale, that pace and that level of activity that it started during the pandemic. And that's one of the things we've been feeding back to the government, and it's in our reports if you want to look at the Poverty and Inequality Commission website. The next thing is the Scottish Government needs to really inform the UK Government on what they need to stop. They need to stop the 2-child limit. They need to stop the benefit cap. Do you know, in 2008, a lone parent did not have to look for a job and was able to receive income support until their youngest child was 16. Under universal credit, that has been reduced to age 3 or 4. We are now putting pressure on parents to find employment when their children are only 3 or 4, but we don't have childcare in place. So that's the thing that Scotland does have control over, and that the Scottish Government should implement at a far greater speed and scale than it currently is, and that is a universal high quality childcare provision, which will also raise the profile and the level of employment in the early years across Scotland. So it would have a double whammy there of allowing people to work and then giving more people better quality work. The other thing I want to talk about was the intersectionality, those people, the gendered aspect of this. The people with no recourse to public funds are refugees and asylum-seeking people, ethnic minorities and folk with disabilities. We have a great focus on that in the Poverty and Inequality Commission. During the pandemic, it was clear to me that when we were making spaces for people to sit out in the streets. What we were doing was preventing people with disabilities from accessing the spaces they were able to previously access. So we need to be communicating with people and communicating with the communities who are affected by these policies before trying to implement them. And I'm sorry, my 4 minutes is up, so I will stop there. Even though I've got loads more to say, I shall stop there, and thanks for listening.
Thank you very much, Maura. It was a very, very full response, and lots of really interesting stuff there. The second respondent is, as I say, it's Martha Wardrop from the Scottish Green Party and Councillor for Glasgow Hill Head. Thanks very much, Martha, for coming along. Please start your response as soon as you're ready.
Thank you, Mark, for the invitation today to speak. I'm here as the Vice Chair of the Environment, Sustainability and Carbon Reduction Policy Development Committee. I have a role in developing policy responses and looking at ways the Council can address ongoing issues around inequality, poverty, and particularly around the environment, enhancing Glasgow's environment for the benefit of everyone. So I'm grateful to be able to hear all the evidence put forward as part of the inquiry. I understand there will be a report produced, so I'm happy to take that forward as part of discussions with other councillors on the committee. That during obviously the pandemic, councillors' engagement in dealing with the public health emergency has been quite stark. Working from home and our usual public engagement has been restricted quite dramatically, but we have continued to meet through online platforms, and our work of the committee has been developing. Particularly at the moment, we're focused on transport. So the transport agenda that's been raised I would hope that people will come forward with views as part of the consultation that being announced around the transport strategy and the active travel strategy that will be happening in the next few months. We have been looking at food growing and development of food growing strategy and addressing land use issues and maximising opportunities for people to get outdoors and be involved in accessing healthy food. So I'd hope that people have contributed to that, but coming back to officers, if you have any points you want to raise, I'm happy to take them up. From my point of view, I've been keen to support green health partnerships, bringing together the third sector with the health service and Nature Scot, working with GPs and health centres to look at how we develop social prescribing and encourage people to maximise the benefits of nature to their well-being, enhancing vacant and derelict land, and look at particularly targeting improvements to green space within the most disadvantaged areas of the city. There are examples of green health partnerships in other parts of Scotland, and I've been pushing for additional developments in Glasgow, bringing together the council and the NHS. The recent days, there's been a lot of talk around the Christie Commission and how we embed preventative spend and decision making going forward as part of the recovery from the pandemic. I think there's obviously in the news at the moment, there's a great deal of concern about hospital beds and ambulance services, and then the winter fear for what's going to happen over the winter in terms of resources. And I think obviously there's a great role here for the third sector in responding as well to this situation, looking at the work of projects such as Healthy Living Centres and the mutual aid work that's happened during the pandemic, bringing people together across communities. I think that area of work and the research that's been undertaken is invaluable, and I'm happy to take that up further with council officials and people in the NHS. Thank you.
Thank you very much, Martha. Appreciate that. And for our last respondent, I'd like to introduce Rebecca Campbell, who's a public health consultant with the NHS Greater Glasgow and Clyde Public Health Directorate. Thank you very much, Rebecca. If you would like to start your response.
I will, thank you. And I feel quite a bit of pressure being the end person, but I think I've got like 15, 20 minutes left to get, no, I'll stick to my 4 minutes. There's been so much today, and it's been really fascinating, and there's lots of common themes, I think, coming across. And the way I thought I would frame the response from a health perspective in terms of inequality, sustainability and engagement, bringing those together, was looking at the NHS as an anchor organisation. Essentially, the NHS is owned by the population and the communities that we serve, and I think often people don't think of the NHS in that way. Anchor organisations tend to be embedded within communities. We've been there for a long time, we're not fleeting, and there's generally high trust within or towards the NHS. But we have the opportunity to contribute to real change. So there are 5 different headings that we can do that under. The first is as employer. We're the largest employer in Scotland. We have the opportunity to be a fair employer, to provide good work, to provide a real living wage, real progression, but also a strategy for positive recruitment. So talking about some of the marginalised groups, some of those that perhaps need more development to get into different roles within the NHS. So very focused and targeted recruitment, focusing on local as well. The second point is as a purchaser. We purchase millions and millions of goods and products and services. Traditionally, price has trumped every other consideration, but we need to move towards ethical and sustainable procurement, and there are policies that can drive that work forward. The third is our property and grounds and physical assets. We have huge areas of green space. They should be for community and local use. They should be developed in that way, while still remembering that a lot of them are within functioning health services and functioning hospitals. So we need to bear that in mind. Also linking to the active travel agenda that's already been mentioned and how we develop that within our green spaces. We have an ethical responsibility. We are required to do no harm above anything else. We shouldn't have sustainability as a sideline. Sustainable care should be central to what we're doing. Green healthcare should be core business. We should be reducing medicinal prescribing where possible and looking at alternative green healthcare solutions, and also significantly reducing our waste and what we throw away. But we should also be pushing for change. Public health traditionally has had less investment than acute frontline services. There's been a lot of focus on pulling people out at the bottom of the river instead of fixing the broken bridge that's up at the top. And we know that prevention is very long term, and there's a lot of downstream pressures. But public health need to be using data to shine a light on the issues. We should be speaking up and we should be speaking out about the fact that inequalities are unjust and they are avoidable. And we should use data to shine the light on that. Health in all policies, we should be pushing for that, and mental health in all policies, and reviewing the health and mental health impacts and the sustainability impacts of any policies within the NHS and externally. We need to push for levelling up, things like universal basic income. We, at the end of the day, are a national health service, and we have become very much a national sickness service, as opposed to focusing on how we nurture health and well-being. And finally, working in partnership. So working with and not doing unto, with our communities, with wider partners, really engaging with lived experience. And somebody mentioned earlier about amplifying voices and seeking people out to hear their stories. That's my timer. We should be listening and we should be learning from our wider partners. And somebody else mentioned being beyond consultation and proper co-production. And my sense from today is we have many people, many voices, and it enables a volume because we're all saying very, very similar things. We want the same things. And there is power in numbers and better coordination between all of us. The NHS can't do it all, and there is so much expertise out there, so much enthusiasm and capacity out with the NHS, especially from our third sector colleagues and our communities. And we need effectively to work together for that change. Thank you.
Thank you very much, Rebecca. Now with the somewhat invidious task of concluding the day, I'd like to hand over to my colleague in PHMS, Dr. Sue Laughlin, who's going to give us her wisdom, which is always fun.
Thanks very much, Mark. As you say, it's an invidious task to try and pull all of this together. First of all, I really want to thank and reinforce what you said, to thank the speakers and the responders, and also the rest of you that are observers for this inquiry. We appreciate that we only gave you a very short amount of time to present your evidence, and I think that I would like to congratulate you all in being able to present some really, really rich evidence in a short amount of time, the 4 minutes. I think actually it's a format that worked pretty well. That said, we don't want to close down this inquiry, and if people want to add to the evidence that they've provided verbally, obviously we're very willing to take that. And if you want to also encourage other people to present information to the inquiry, we would be very pleased to receive it. As Neil said at the beginning, this is just the beginning. This isn't just a one-off and that we will be going away. We are looking for more contributions, as I've said. We're going to make the contributions that we've received already available, and we are going to turn everything that we receive into a report. There is, of course, a danger that with a report it just is a document that doesn't go anywhere. So what we plan to do with the report is to share it back with you as participants, both as speakers, responders and observers, and invite you to comment on the report and come back and talk to us about what you think you've got from this day and what you've got from the report. But more importantly, I think it is how we all act together, as the last speaker has said. There's been a very consistent theme of exacerbation that's come through all of the presentations, that COVID hasn't set a new set of issues in train. All it's done is made things that already exist much worse. We've known about the causes of poor health for a long, long time. And similarly, we've known about what we need to do about them. But yet we keep on returning year after year after year, talking about the same issues. And that improvement has not occurred means that we need to up our activism and our campaigning and find ways of working together so we can push for the alternative policies that people have been arguing for today. PHM is a global organisation. As Neil said at the beginning, there is a UK component to this, there's a European component, but there's also PHM Scotland. And we would urge you to come and join us in our efforts of both raising the profile of the issues that you've talked about today and working with us to campaign for further change. We're particularly keen to try and translate what people have said today into the context of Glasgow. We are aware that there are efforts underway to bring forward an alternative agenda for Glasgow. And as one of the speakers has said, the health of Glasgow is notoriously bad, and we know the reasons for that. We also know that there are actions being taken at the moment which are likely to exacerbate that word again, the health problems of Glasgow with the cuts in services and facilities. So we want to try and bring together this evidence and put it forward as part of an alternative people's plan for Glasgow. That's not to say that we won't also have the information available that can be used throughout Scotland. So just to conclude, thank you very much, everybody, for participating. We've all been sitting here for a long time. It's been a very, very, very informative and interesting session, and we hope that you will join us in the next stage. We will put in our information to all of you, and we hope to see you at our next meeting. Thank you very much. So that, I think, just concludes the session today. If anybody wants to make any points, please put them in the chat and we will follow them up. But other than that, I'm going to ask Tony to end the proceedings. Thank you.
Will do. Thanks, everyone. Thanks to all the contributors. We'll be in touch soon. So, thanks, everyone.
Thanks for doing such a brilliant job with the tech.
Thanks, everyone.
Yeah, thanks. Bye.
You gotta go, Sue. Well done, everybody. I think that was a sterling effort. You're on mute.
Yeah, I was just
I'll catch you all later. I have to go.
getting rid of people.
Okay.
Right, that's everyone gone. Yeah, thanks everyone for the help. So
Well done, everyone. It was amazing.
Oh,
thanks,
hi,
Julia.
Julia. Nice to hear from you.
Yeah.
Will we all catch up on Monday?
Yeah. Speak on Monday.
Good for me, yeah. So.
Lovely to see you, Julia. So sorry.
All right, guys. Yeah.
Bye,
Likewise.
guys. Bye.
All right, see you
Bye.
guys on Monday.
Okay, bye.
Bye.